Hi, everyone. We're going to give it about 2 minutes before we get started. About 1 more minute.
And you can see me and hear me?
Yep. All right. Well, welcome, everyone. I'm Tom Walker, Executive Director of Encore Outpatient Service. Thank you for joining us today for our series DMV Neighbors in Treatment and Recovery, a spotlight on local resources, programs, and expertise. Every week, we've been highlighting a different provider in the DMV region to provide you with insights and resources you can utilize in your practice. Please note that these sessions are not eligible for continuing education credit. We will be conducting these sessions in webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions you may have. We will have time for questions at the end of the presentation. This week, we welcome Denise Tordella, who's a licensed professional counselor in Alexandria, Virginia. Her area of clinical specialization is integrated trauma-informed mental health and substance abuse treatment. She's a workshop presenter who provides training and consultation to universities, nonprofit organizations, and municipal mental health, substance abuse treatment providers on the local and national level. Denise will be speaking today on the topic of women and addiction, trauma-informed, gender-responsive treatment. Please welcome Denise.
Hi, thank you all for coming today. I look forward to talking with you about a topic that I'm really very passionate about. I'll give you just a little bit of background about how I got involved in this type of work. Becoming a therapist was a midlife career change for me. And I'm almost sort of embarrassed or reluctant to say I'm now more than 20 years into my second career. So been a long time. I was fortunate to do my internship at Arlington County Behavioral Health. And I worked in what was called the dual diagnosis program then, meaning that all the individuals in that program had a history of substance abuse and a co-occurring mental health disorder. And as I was working with the individuals in the program, it became pretty clear that there was something else going on, and that was that many, if not all, of the individuals I was working with had significant histories of trauma. And so I began to become curious about how was that also affecting their treatment, that although we were doing integrated treatment for their mental health and substance use disorders, how were we addressing the trauma? And back in the very late 1990s, early 2000, the direction that we were being given was don't talk to them about the trauma for a variety of different reasons, and that it would be an impediment to their treatment. So I worked with that for a while, but saw people really relapsing a lot and having a lot of difficulty in emotionally regulating themselves so that they could achieve and maintain abstinence and also achieve stability with their mental health disorder. So I did some research and found the work of Lisa Najovitz. She had, in the early 2000s, published a curriculum called Seeking Safety. And I still use that curriculum today. Over the years, I became involved with an organization in Alexandria called Friends of Guest House. And Friends of Guest House works with women who are re-entering the community after a period of incarceration. And 99% of the women also have histories of trauma and have significant mental health as well as substance use issues. So that's how I got involved in looking at women and addiction and men and addiction and trauma. And I completely acknowledge that men have trauma and men need gender-specific treatment. There is no one size fits all. And today's webinar is going to be focused on women and addiction. There's a lot of really good resources out there. There are a lot of really good resources out there on working with men in addiction, especially the work of Dan Griffin. So if you're interested in learning more about specifically working with men through a trauma-informed lens and addiction, I would highly recommend starting with some of his work. Okay, I'm very open to answering questions, and the way the format was explained to me, that we will leave time at the end for questions. If you have questions and you want to put them in the chat box as a way to remind you and to remind me, we will definitely spend some time at the end answering any questions. So, women and addiction. What are we doing here? My slideshow is not cooperating. What happened? I am screen sharing. This is not good. Oh, here we go. It just had to wake up. All right. So why are we here? So we're going to talk about sex and gender differences that affect women's experience with substance abuse, treatment, trauma, treatment services, and recovery. Look at what are the core elements of a gender responsive program, and also to look at why it is that women initially initiate substance use. As I said, I've been doing this work for many, many years, decades now, and I've yet to come across someone who says to me, I just woke up one day, Denise, and thought that misusing substances was the way to go. So the work of Gabor Mate, he talks a lot about addiction and trauma, and I like this quote, which is, "It is impossible to understand addiction without asking what relief the addict finds or hopes to find in the drug or the addictive behavior." He also says that when we're working with addiction, we're working with pain, and we have to be able to address the pain in order to address the addiction as well. So when we're thinking about how prevalent is trauma in women's lives, approximately 50% of all women will experience a traumatic event in their life. Women are more vulnerable to sexual assault and childhood sexual abuse. 1 in 5 women in the US has been raped, and women are diagnosed with PTSD at 2 to 3 times the rate that men are diagnosed. For those of you, and I would imagine most of you, are familiar with the Adverse Childhood Experiences study, which has shown that there's an increase for substance use and mental health disorders. The higher the number of positive responses to have you experience this traumatic event, the more likely it is that the person will have a mental health or substance use disorder. And if you kind of just think about the questions, and think about the people that you're working with, the higher the positive responses to the traumatic events, the more likely it is that the individual will have a substance use and mental health disorder. And one of the articles that I read in preparation for this said that people who score a 7 or higher on the ACEs study have a 980% higher risk for a substance use or mental health disorder. 80% of women seeking treatment for a substance use disorder report a history of physical or sexual assault, and women with PTSD and substance use disorders have higher rates of other co-occurring disorders, anxiety, depression, eating disorders. So there's what I'm trying to say here is that trauma definitely increases people's risk for substance use and other disorders. I did give a quick slide. I'm not going to go through all of it, but I invite you to look at it about the ACE factors that I was just talking about, and just kind of going through in your own mind the people that you're working with and how many of them would endorse that they had experienced any of these incidents. Okay, another thing that is important to remember is when we work with domestic violence survivors, that 42% of domestic violence survivors had substance use forced upon them, and women who have been abused are 15 times more likely to abuse alcohol and 9 times more likely to abuse other drugs. And that's something that we need to really be aware of when we're working with women, especially that statistic about the substance use being forced upon them. For some women, it is absolutely forced upon them. It's part of the cycle of abuse, part of how they are controlled. Another thing that I have found in working with women is that some of them actually initiate substance abuse as a way to connect with their substance abusing partner. I can remember a woman sitting in my office. I'd see her on Monday mornings, and she just had tears streaming down her face. And so, of course, you ask, okay, what's happening? What's going on? And she goes, I'm so embarrassed to tell you this. We've been talking about the issues with my husband's substance abuse and how it's affected our relationship and how it's affected our family, our children. And she said, I am now abusing cocaine. And I said, so tell me a little bit more about that. And she said, I thought that was a way that I could finally connect to him. So being really aware of how women use substances or how substances are forced upon them helps us to understand the context in which they are using alcohol and drugs, and then what issues may come up for them should they decide to come into treatment and abstain from the use of alcohol and other drugs. Okay, one of the leaders in the field of gender responsive treatment, especially around substance use disorders, is Stephanie Covington. And she talks about the gender differences in abuse. In childhood, she says girls and boys are at equal risk from family members and people that they know. In adolescence, there's a shift. So young men are more at risk from abuse from people who dislike or hate them. Boys are at greater risk if they're gay, young men of color, gang members, or that they are transitioning. And here's the break. Women are at risk from lovers or partners, people to whom they are saying, I love you. So for women, the shift becomes that they experience abuse within the context of relationships that are supposed to feel safe, that are supposed to feel secure. So the very people who are supposed to love and care for them become the people who are abusing them. In adulthood, men are more at risk from combat or being victims of crime. women are most at risk from those they love. And for transgender people, they are at the highest risk for abuse. So we have to really take that into consideration when women are coming into treatment, that women have been abused within the context of relationships that are supposed to be safe and loving, supportive, and caring. And just beginning to think through, how does that affect the woman coming in for treatment, and what effect will that have on the therapeutic relationship? So we've all heard different definitions of trauma. This is your pretty basic one: the event, witnessed, or experience that provides a threat to one's physical integrity or survival. Here's where another piece of this is really important, though. Responses can go across a continuum, and there can be many different responses to trauma. People can have intense fear, they can have helplessness, horror, a sense of being disempowered, anger, or rage. And that is going to influence how they deal with the trauma itself, what their range of emotions were at the time and continue to be as a result of the trauma. And we've all seen the difference between working with a client who's really shut down, disconnected, numb, and we also know that based on if that's their response, what types of drugs or alcohol or the effects that they're looking to get from those substances might be as compared to someone who is struggling with anger or rage as it relates to their trauma. There's also the tremendous shame, the guilt, the badness, the embarrassment, and then the profound grief that comes as a result of trauma. I mean, we're right now in this pandemic, we're all experiencing, or many of us, I shouldn't say all, many of us are experiencing a sense of loss. And we're dealing with our own grief and also our own uncertainty about what our world is going to look like and how are we going to get this under control and get it manageable and get back to some sense of normalcy. So we've all experienced a bit of grief. Normally, I'd love to give these webinars, well, they're not webinars. I love to give these workshops with the people so that I can interact and we can all learn from each other because we all have so much of our own wisdom. And not being able to do that is a loss. So the people that we work with who have experienced trauma have experienced many losses. So here's what I really would like you all to leave with from today. That doesn't mean you can cut out of the webinar, but from a treating substance abuse from a trauma-informed perspective and providing trauma-informed care, that we recognize that many behaviors and responses are directly related to the trauma, that we understand how people coped and adapted to these traumatic situations and how they are continuing to use those strategies in the here and now, where they may no longer be as effective and as efficient, and that we understand the triggers for people and the unique vulnerabilities of a trauma survivor, and that we plan our programming and our treatment around all of these concepts. One of the, I think one of the things that happens in working with our clients, working with women, is that they also do not necessarily always recognize that they have experienced trauma. It depends on what the trauma was, how the people around them put it into context for them. Many, many women do not really understand um, and recognize what they experienced as traumatic, especially if within their environments um, they had seen it happen to other people. I do consultation for the City of Alexandria's Domestic Violence and Sexual Assault Awareness Program. And one of the things that the clinicians sometimes find challenging is when they're working with a mother and a child, and the child has reported the abuse. The mother has reported the abuse because that's what she needed to do. And then they come into treatment, and the mother says to the therapist, I don't know why we need treatment. She's just going to have to get over it. She's just going to have to move forward. The perpetrator is away from us, out of the house, away from her. So she just has to get over it. And the clinicians are like, no, she's not going to just get over it. And what we've learned over the years is to then explore what happened to mom. Did mom experience physical abuse, sexual abuse? What kind of traumas did mom experience, and what kind of support that was she given? And so what we've been able to do is talk with mom a little bit more about her experiences and label them for her, and talk about how different things might have been had someone been there and been supportive and helped her. So I think that it's really important. We all talk about trauma-informed care. Trauma sometimes is even a word that some people find it's being overused. But we do need to educate women as to what abuse is and how it affects them. And they also don't understand PTSD. Like, we think, okay, you get PTSD if you're in combat or you're the victim of a violent crime. They don't understand how you can have PTSD as a result of relational trauma as well. So those are important things. And then the other thing is to always normalize their reaction. Years ago, I worked with a young man. He had a lot of trauma in his life, and he was smoking a lot of weed and drinking and really putting himself in really dangerous situations. And he got arrested, and so he had to, part of his probation was he had to stay abstinent. So he came into treatment with me, and he told me, his story, a little bit about what was happening and what he was doing. And I helped him to make that connection between his substance misuse and the trauma. And he looked at me and he said, and I'll edit it out because we're being taped, but basically he said, so I'm not just crazy? And I said, no, you're not just crazy. This makes sense within the context. However, it's not really working for you. So let's find some things that help you to manage your emotions and understand the impacts of your childhood trauma that don't wind you up on probation. And it was an interesting exchange for me as a therapist and for him to understand the impact of trauma, and that his behaviors and his responses were not crazy, but they made sense within the context of the trauma. When we're looking at trauma-informed care, we design therapy that, as I just said, acknowledges the impact. We put a lot of emphasis on physical, psychological, and emotional safety because our trauma survivor clients do not feel safe. We help them rebuild a sense of control. We are sensitive and respectful. We're respectable too. And we understand that their symptoms as adaptations to a world that has not always been safe. Sometimes when I'm talking with a client and they're telling me part of their trauma narrative, I'll pause and ask them, well, how did you cope with that? How did you deal with that? And again, I remember a woman who literally started drinking when she was 9 years old. And she said to me, you know how I cope with it. I drank. I told you that. And I said, yeah, that makes sense. There wasn't a whole lot else available to you as a 9-year-old and living within all that chaos. And when we're able to help our clients understand the symptoms of adaptations, we reduce the shame and the stigma. So when we're talking about trauma responsive environments, we talk about it being safe, both physically and emotionally. And for those of you who work in residential programs or intensive outpatient programs, as well as seeing clients individually, I invite you to think about these characteristics of that environment, that it's safe, both physically and emotionally, that we are trustworthy, that if we say we're going to show up, we show up. And if we can't, we acknowledge that we can't. Our clients will be testing us. We know that. This is their survival skill. So we have to be reliable and predictable, and we have to hold boundaries, absolutely. Our boundaries have to be consistent, not necessarily rigid, but they have to be consistent. That's how we build trust in the relationship. Being able to give the people that we work with choice. And I have worked in residential programs. I have worked in municipalities. I know that that's not always easy, but there are ways that we can give some choice. Would you like to sit in that chair or this chair? In a residential program, many times when a client comes back, we have to search their bags, so to speak, and we can say, okay, how do you want to do that? Do you want me to take the bag from you? Can we do it together? So it's finding ways to provide choice. And that's part of the healing process, still within the confines of the rules of the program. Collaboration. What do you want to work on? What's most important to you right now? What's most important to you today? And empowerment, helping clients to reclaim their voice, to learn how to advocate for themselves, to even be able to say to us, I don't want to do that, and say, I get you don't want to do that. It took a lot of courage for you to tell me that. That's empowering our clients. Even if at the end of the day, what we're asking them to do is something that they have to do in order to stay in the program. So a little bit more about using that strength-based approach. We have to validate the relief that is offered by the addictive behavior, by the addictive substance. Okay, we have to help clients understand that link and what that substance gave to them, so that we, as their therapists, can collaborate with them to find other ways to get relief from what they're feeling without using substances. And I always acknowledge right up front that things like breathing and grounding and things we'll talk about later are not going to be as effective and as efficient as their drug or alcohol use. And it's not going to have negative reverberating effects for them. And remembering too that trauma survivors really struggle with the fear of relying on people and the lack of safety in relying on people, as opposed to the safety in relying on a substance or a behavior under your own control. It's really difficult to imagine giving up, knowing exactly how I'll feel if I have a drink or use drugs, versus I'm going to reach out and talk to somebody. I'm going to go to an AA meeting. I don't think so. My experience has been in trusting people that's when I really got hurt. So it takes time. It takes our patience as clinicians. A lot of times I've heard people say, well, when you're working with people with addiction, they lie a lot. Yeah. So we can say, okay, they are pathological liars. Where does that get us? But when we take a step back and realize that trauma-related shame and secrecy make it feel normal to lie and evade and unsafe to disclose. Kids who've had childhood trauma, part of what they've been told is, don't tell anybody about this. Do not tell anybody about this. So it's not safe to talk about those things. I've worked with people who didn't come into therapy until the perpetrator of their childhood trauma died. That's when they finally felt it might be safe now to talk a little bit about it. We also have to put it out, be aware within ourselves of the struggle in which the therapist becomes the spokesperson in favor of sobriety and the client becomes the spokesperson for addictive behavior. So right there, you're setting up conflict. Conflict's not going to work. We need to set up collaboration. We need to become really familiar with that. So on the one hand, this, and on the other hand, that, so that we get some buy-in from the client on what the benefits of sobriety are for them. And sometimes it's something really basic like you won't go to jail. And that's okay. For those of us who have been trained in motivational interviewing, that's a great place to start. Anyway, another definition of trauma-informed, it's not what's wrong with you. It is what happened to you and how did you survive. Here's a list of some of the traumatic stressors that people have had, similar to the ACEs study. You can look at those on your own. I love this quote from Bessel van der Kolk because I think it really helps us to understand what women and all trauma survivors are dealing with and why they use substance use. The lives of many trauma survivors come to revolve around bracing against and neutralizing unwanted sensory experiences. At least half of all traumatized people try to dull their intolerable inner world with drugs or alcohol. And it does give them a sense, a false sense, and a paradoxical sense of control. And at the end of the day, their diagnosis will come to define their reality without ever having been identified as a symptom of their attempt to cope with trauma. And as we do lots of psychoeducation with the women that we work with to help them to understand that, to make that link, to make that connection, we reduce the shame, we reduce the stigma, and the woman is less blended with all of that shame and stigma. You know, that's one of the things. Of course, men experience shame and stigma. We're going to talk a little bit more in a few minutes about how it affects women in treatments differently than it affects men. So trauma is a risk factor for substance abuse. And then our clients who are using substances, it's a risk factor for more trauma. We've all heard the stories of, people getting arrested for DUIs, using drugs. Many of the places that our clients go to buy drugs, they're not going to CVS, okay? There are definite risk factors in going out to get drugs. And as a result, we're just laying trauma on top of trauma on top of trauma and making it even more difficult for people to function in the world. The other thing that I hope that people leave with when we're talking about addictions and trauma is that behavior is not fun and pleasure seeking. It is an absolute survival strategy. This isn't like having a beer on a Friday night with your friends, which of course most of us can't do now anyway. We can't even see our friends. But it's really about, how do I survive? How do I get through this day? What are the functions? We've talked about some of it. It's to self-soothe and self-regulate, numb the symptoms of hyper or hypoarousal, combat their feelings of helplessness, wall off intrusive memories, or to function or feel safer in the world. And this is you can use this as a template for figuring out what skills the woman that you're working with needs in order to be able to accomplish these things for herself. What does she need to learn about self-soothing? What does she need to learn about walling off intrusive memories, stopping flashbacks? So this can give you a basic place to start to do an assessment of what kind of coping skills does she need. Clearly, the presence of traumatic stress will complicate the recovery, and it's simply more difficult for women to achieve abstinence and maintain it. However, that does not mean that they can't. It just means that we have to do a lot of skill building, a lot of psychoeducation. We have to be able to identify their barriers to treatment, the shame and the stigma, obviously, economic challenges, do they have the money to go to treatment? Issues around childcare are huge, absolutely huge. And then for women who are involved in relationships where there may be issues around child custody, many of them are very, very reluctant to come into treatment because that could be used against them. So we want to, in order to help women, we want to provide a lot of hope, compassion, and information. Be able to access their strengths and prior successes. Many times when we're working with people, some people choose to tell us their trauma narrative. I'm always very careful about that, always staying with the woman to make sure that she's not re-triggering and re-victimizing herself, re-traumatizing herself. Well, when they talk about, okay, this happened, this happened, this happened, I say, can we just pause for a moment? And then they'll kind of look at me and I'll say, is that okay? And they'll go, oh, yeah, all right. I said, how did you get through that? And that gets them out of the narrative of, we all learn in graduate school. If the individual doesn't seem connected to their story, you need to call them on that. Maybe not so much. However, that is a good time for us to pause and help assess what is actually going on. And when you say to an individual, wow, how did you get through that? That breaks up the narrative, gets them out of that victim mode into, well, yeah, actually I did survive, like I'm sitting here telling this story to you. And it helps us access their strengths because we learn what it is that they were able to do. And then we're able to help them set goals for themselves. We set them to be small and achievable. The piece about AA where it's one day at a time. That's exactly it. It's one day at a time. And then when they do have have success, we shine that spotlight on it. We make it as big as possible. And then we help them to connect with that part of them that was able to achieve things. I'm also trained in sensory motor psychotherapy. So I'm very much teaching clients mind-body techniques to develop the capacity to self-soothe, breathing, grounding. When I can get them to go to yoga and 12-step recovery, there's so many resources out there that we can use, and they just try them. If it works, great. If not, we'll try another one. These are some things that we can also help them to do, encourage participation in activities, draw on their spiritual beliefs, really help them, as I said before, appreciate their new strengths, their skills, their insight, and help them connect with themselves in a confident way. We want to be sure to make one of the differences for women and men physiologically is that there are a lot of risks to women's health from alcohol. There's a lot of risk to men's health from alcohol, but these seem to occur earlier in women and with more severity. So help, again, one of the ways sometimes to help a woman engage in treatment is to help her understand through psychoeducation what she's actually doing to her body. And certainly working with women who are pregnant. That's a whole nother webinar for another day. But basically, women who are pregnant, we need to be able to bring them into treatment. There are a lot of treatment protocols for women who are pregnant who are using opioids, so we can help them have a healthier pregnancy and then a healthier child. It's important to screen pregnant women for substance abuse, provide education, and again, rather than shaming, connecting women with community resources, enhancing their inner strengths, and teaching them about advocacy. As I said earlier, my women who are with the women that I work with in the criminal justice system, it's the abuse to prison pipeline. And they have a high risk for relapse when they leave jail, and they need treatment post-incarceration. With women where domestic violence may be an issue, we need to assess for domestic violence in a private way that's respectful, and that takes into account the woman's need for safety. And we also have to recognize that sometimes when women are in situations where they're at physical risk, that their survival and safety strategies may conflict with recovery strategies. So we need to be able to provide an environment to discuss that with them and support them in having in place what they need to have in place in order to stay safe. Adolescent girls, it affects their brain development, it affects their risk, their ability to assess their own risk, and definitely problems in school, and just making bad choices, not being able to stay and advocate and keep themselves safe. When we're looking at barriers for treatment, awareness of the stages of change, making sure that the women feel safe, and identifying what their caregivers' treatment issues as well. So one of the goals in treatment is to teach women how to self-regulate. So we have to teach skills that calm down the limbic system. Many of you may be familiar with the window of tolerance, where we're in the middle here and we're kind of just hanging out. Whatever we're hearing, we're able to integrate. Our clients who abuse substances have a teeny, teeny, tiny window of tolerance. They're either hyper-aroused or hypo-aroused, and they use the alcohol or other drugs as a way to regulate their arousal. So we have to teach them other things. And it's helpful to use this graphic, and you will get the slides after this is over, so you can show clients about the window of tolerance and get them to say, okay, so where are you today? It's also important to talk about relapse, okay, and how especially the abstinence and relapse cycle works with PTSD. And that's what this chart helps you to understand, that many times when people initially stop their substance use, they get an increase in their PTSD symptoms based on everything that we've been talking about already this afternoon. So again, here's a graphic that you can use to attempt to help them identify where they are most at risk and what they can do to break the cycle. We want to provide them with skills for safety and stabilization. And I put these, as I said earlier, in the handouts. We're not going to obviously have the time to go over all of them, but they're things that you can reflect back on. But remembering that teaching these skills initially is the most important real trauma work we can do. I have spent sessions teaching people literally how to breathe. The whole session. Because they did not know how to breathe in a way that regulated their nervous system. They were constantly gulping for air and shallow breathing. We all work with our clients to develop safety plans. How are they going to take care of themselves? That's for even taking care of themselves for some clients is like such a new idea. What do you mean? I take care of everybody else, Denise. I don't. What is this? This is selfish. And again, being able to help them understand how that behavior, that thought, that core belief came from childhood and from being abused. And that now as an adult, taking care of yourself is important, and it is what adults do. So my dear friend, Lisa Ferrance, and mentor, developed a safety plan called Caress. Communicate alternatively, release endorphins, and self-soothe. I will send that handout with her permission. I do have her permission as part of the materials after this. So you can take a look at it and work collaboratively with the women you work with to develop their own safety plan. Again, here are some slides on grounding. I'm going to skip through them. These all come from Lisa Najevitz's book, Seeking Safety. And it is critical to teach our clients to be grounded. And these are some techniques that we can use, that they can use. Post-acute withdrawal, important to be able to educate clients around that, what it might look like. I've had clients come to me and say, I went to that AA meeting that you told me about. Yeah, it was great. They're all in there talking about feeling happy, joyous, and free. I'm not feeling happy, joyous, and free. So it's important to help them understand that initially you're not going to feel so happy, joyous, and free. And this is why. Even though your drug screen may come back negative, there are still effects on the body and the brain that can take some time. And then again, this helps us look at, okay, where do you need support? Where do you need skills? Recovery support, being able to anticipate, manage, and cope. We used to call it relapse prevention. Now they've given it a more positive spin as far as being recovery support, helping people manage reminders. And I got this from a podcast I listened to, but I liked it. Addiction is being frozen. Sobriety is about defrosting. A lot of things will come up. And so we help them to understand that. If someone does relapse, we look at it as a learning opportunity rather than a failure. What did you learn? And then we can focus more on the implementation of new skills, new ways of thinking, increasing their resilience and decreasing their shame and self-loathing. Understanding triggers, help them understand triggers, help them understand their fight, flight, freeze response. Another colleague and I gave a workshop on addiction and trauma, and she pulled these together, these support strategies that are apps that people can use. Developing the coping plan, what's the trigger, what's the early warning signs, what's the strategy. Here's something that's really important too, because we're just about out of time. But for, again, as I said earlier, women are traumatized within the context of relationships. Women heal within the context of relationships, safe relationships. And there are different ways that we can help women develop that sense of safety encourage them to go to all women AA meetings, the women who are receiving services at Friends of Guest House go to women-only meetings for a variety of reasons, but mostly to develop a safe network. When the women come from institutions, jails, prisons, they're so vulnerable. And we want them to be able to keep the focus on themselves, not focus on relationships, because once they focus on relationships, they completely stop focusing on themselves because that's what they knew. Always we're aware of multicultural considerations, people's backgrounds, how to utilize the strength-based approach based on people's culture. I always throw this in because I think it's so important. For those of us who work in the field, we will experience secondary trauma, and the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. Seek regular consultation and supervision. Be flexible. Okay, if one approach doesn't work, try another. Be realistic about your expectations and hang in there. Predictability isn't formal. 2 steps forward, 1 to the side, 1 back, 3 forward, 2 back. That's how it goes. This is not a linear process. And take care of yourself. You're too valuable a resource to completely deplete yourself in the name of work. Nourish and nurture yourself, because those hypervigilant women clients, they're watching you. You can't be in there telling them to take care of themselves when you're not doing it. They know. And remember we talked about building up trustworthiness? That's part of it. You have to, walk the walk. And we give them hope. We give them empowerment. And we give them flexibility and connection. So that's the end of the slideshow. I am going to check the chat box and see what's in there.
I'll read it to you, Denise.
Okay.
So the question that came through is, do you ask that clients are sober before starting trauma work?
Do I ask that they be sober? There are limitations. Okay. So wait, reset, Denise. Before starting trauma work is safety and stabilization. So we do education around everything that I've just talked about today, about how substance use and trauma are interconnected. So that is the beginning of trauma work. Okay, do we get deep into the trauma narrative? No, because that's simply not safe. As we need our clients to be present in today and have coping skills and resources. So the trauma work is, as it said on that other slide, the trauma work is that we begin the phase 1 of trauma treatment, which is safety and stabilization. And in Lisa Najevitz's book, she has some great handouts and information to share with clients exactly about that, and strategies, some language to use too.
Right, and we've known each other for a good number of years at this point, and from, as a administrator in a higher level of care, right, in partial hospitalization, intensive outpatient, and I've known you since I was working in residential settings more. That's really what you're looking for when you refer to a higher level of care as well, right? Stabilization.
Yes, I'm sorry. Yes. Phase 1 of trauma treatment, safety and stabilization.
So in your experience, how long, I mean, I know it varies, but how long does it take for someone to move on to the next stage and move into processing?
That's a difficult question. Some people want to do the processing right away. And so sometimes we have to be respectful of the where the person is. And sometimes I ask just that real common sense question. When you talk about that, do you feel better or worse? I had a male client who came in, and this is in my early time of talking about trauma. He had an appointment with me at 10, and he'd want to talk about the trauma. And he had a really significant substance use disorder. And then he'd leave my office and he'd walk over to Joe Theismann's, where the bartender was expecting him, and he would have a big glass of gin. So finally, he decided he would tell me that. and, that gave us an opportunity to kind of revise what we were doing, because clearly he wasn't ready to do that. He didn't have the capacity to self-regulate. So it's helping people to be able to engage their own capacity to self-regulate. And things are always going to pop up, Tom. They're going to see something, they're going to read something, so they're going to get triggered. So it's how we help them manage that trigger as well. Some people will say to you, I will never tell you what happened to me. I'm like, okay. But we do have to look at how it's affected you.
That's it. And I was thinking as you were talking also about the opposite, how oftentimes we'll see individuals that, come in for an evaluation and essentially unload the entire kind of trauma story and trauma narrative, in one shot, like here's all of it.
Right. That's actually our job, to get them to pause. Okay? Because we do want them to pause, and we want them, this is where we talk about using kind of mind, body. What do you notice when you're talking to me about what happened to you? What are you noticing coming up for you? Well, I feel overwhelmed, or I feel disconnected. Okay, well, what can we do to help you feel less overwhelmed or less disconnected? Because for some people, I talked about, for some people, they don't recognize that they've experienced trauma. For other people, they're so blended with their trauma narrative, they're the ones who come in and just put it all out there all at once. So we can slow them down. And we can always say, your story is so important, but let's be sure that you can tell it safely and feel connected to it and manage everything that comes up as you talk about it.
Yeah, and that's hard. That's hard work for us to slow things down, right? Something to
It
meter.
is. Yet, when we talk about our own self-care, it is important, because we can find ourselves dissociating or getting overwhelmed by someone's trauma as well. So we have to pace that with them so we can stay with them.
I appreciate you bringing that up, and I'm thankful for your time and putting this presentation together for everybody. In the last minute or so here, I know you're doing workshops, and I know you're very passionate about Friends of Guest House. Do you want to put a plug in for the workshop that you have upcoming, and anything else you want to say about Friends of Guest House?
Well, as you said, I'm very passionate about Friends of Guest House. It's a successful program. We women who complete our program, who stay in residential for 6 months and in our aftercare step down for another 18 months, their recidivism rate, which means return to jail or reoffending, is less than 10%, while overall the recidivism rate is 70%. These women are amazing women. They inspire me every day. And so it's Friends of Guest House, just all the way it is, .org. And I really encourage you to check out their website and if it moves you to find a way to become involved. The women need a lot of people to help support them in skill building. So it's through volunteering, mentoring, as well as, of course, always donating. My next webinar is on women and addiction, and it's through the Ference Institute. And for those of you who are going to have the slides, Lisa Ference's name is on some of the slides. So look it up. It's in September, like September 22nd, I think. I should know this. And of course, it's virtual. And honestly, the last one was my first virtual one and got a lot of really good positive feedback. So we're able to take everything that we talked about in this hour and dive deeper.
Got it. Well, Denise, thanks again for.
Oh, you're very welcome. Thank you for inviting me.
It's always a pleasure. And everyone, thank you for joining us and logging in today. Moving forward, in the month of August and going forward after that, we're going to be moving our webinar series to a bi-weekly format. So 2 every month. We'll be back on Thursday, August 20th at noon with our next speaker, Vanessa Terry from Perry Nutrition. She will be speaking on the topic eating disorders, disordered eating and addiction recovery. Registration is open for that now. We will continue to send out communications, so watch your email for details on that and other upcoming presentations. In the meantime, please feel free to reach out to myself for Encore Outpatient Services, Mallory Schwartzman at Maryland Addiction Recovery Center, Jess Ayer, who represents Caron Treatment Centers in the state of Maryland, and James Flenche, who represents Caron Treatment Centers in Washington, D.C. and the state of Virginia. Once again, thank you, everybody. I look forward to seeing you again in a couple of weeks.
Okay, and if you have any questions, my contact information will be on the PDF of the slides, so feel free to give me a call.